Hello everybody, welcome to Community Conversations here at Atlantic Health System. My name is Luke Margolis. I am the Corporate Communications Director for Atlantic Health, and today I am pleased to be joined by two physicians who are going to be talking about a very important topic of conversation with me, and that is, of course, atrial fib or AFib, heart health, and stroke prevention, and the connection between those three things. And so I want to introduce my doctors, starting from closest to me and then further to the left. Seated directly next to me is Dr. Michael Katz with Atlantic Medical Group. He is the director of the Inherited Arrhythmia Program here at Atlantic Health System. Doctor, thanks for joining us.
Thanks for having us.
And to his left is Dr. Timothy Mahoney, also with Atlantic Medical Group. He is the co-director of the Electrophysiology Lab at Morristown Medical Center, part of Atlantic Health System. So, Doctor, thank you for joining us as well.
Thanks for having us.
All right, well, we are going to chat for about 15 to 30 minutes, as we usually do here on Community Conversations. For those who haven't seen it before, here's how this will work. We have some prepared questions and some questions that were submitted by some of you, our audience, ahead of time. But if you hear something that you think is interesting and you want us to follow up on, feel free to enter a question in the chat portion of the window, and we will try to get to as many of those as time allows. If for whatever reason you got to drop out, you can't see the whole thing, or maybe your internet connection goes, this entire program is being recorded as well and will live on our social media accounts, on our YouTube channel, and you can always find it and all of our community conversations on our website, atlantichealth.org. So, all of that having been done, let's jump right into it. We do have a lot of questions, and they range from the super specific to the more general. So why don't we start first with some of the general stuff, and that'll then allow us to dial in. Dr. Mahoney, if you would, let's start with just a real basic global overview. What is atrial fibrillation?
So, atrial fibrillation is an abnormal rhythm that starts in the upper chamber of the heart. The way our heart coordinates blood flow throughout the body and responds to our body's needs is with electrical stimulation that makes the heart beat in an organized fashion. What occurs with atrial fibrillation is the electrical system is short-circuited in a way, and no longer is the heart beating in a rhythmic fashion. That has three main issues. First of all, it can cause symptoms of shortness of breath, lightheadedness, palpitations, and severe fatigue. It can also, in very rare circumstances, cause the heart to beat so fast and irregularly that the heart will fail and go into something called heart failure or develop poor pump function of the heart. For today's discussion, most importantly, is that when the heart is in atrial fibrillation, the upper chamber on the left side of the heart is going so fast it cannot move, which is counterintuitive, but it doesn't have the time to rest and squeeze. Because of that, atrial fibrillation can cause the blood to pool in the upper chamber and a clot to form, and that is why strokes can occur in atrial fibrillation. So in summary, atrial fibrillation is just the heart short-circuiting in a way that it can affect both the heart's function, how the patient feels, and cause issues with clotting and stroke.
Dr. Katz, we got a lot of interest in this topic. There were a lot of people that reached out to us to submit some questions. How common is AFib? Is this something that you see a lot of in patients, or is this a fairly rare condition?
So not only is it a very common condition, but I think it's being discovered in a more frequent way, not only by physicians, but by patients themselves, both with monitoring tools and even just in the community. We joke amongst ourselves that AFib is turning into a little bit of an epidemic, because not only is this a process that shows up with maturity, but as people do become older, it does become more common, to the point where, in people's 60s, 70s, 80s, this is a very common referral for us to see in our practice.
For those who are maybe hearing about this for the first time and want just a resource where you can find more information on this, we have done a Facebook Live on this topic before, and so a lot of that information is accessible through our website, again, atlantichealth.org, if you want to click on there, of course, after we finish. Of course, you wouldn't want to go now, not while we're talking. Picking up on what Dr. Mahoney was talking about, this relationship between AFib and stroke. Is AFib then makes stroke more likely? It increases the possibility of stroke? Or let's talk a little bit more about that connection and how some of those things manifest themselves.
So atrial fibrillation makes stroke more likely. Okay, most patients with AFib, all patients with AFib should be risk stratified as to how likely they are to have a stroke for clinical reasons. But if you look just at from the ground level, patients with AFib are about 5 times more likely to have a stroke. In addition, because of the mechanism of stroke in AFib, strokes in AFib not only are more frequent than in the general population, but they tend to be more severe. The stroke patients usually do much worse if their AFib causes the stroke. And in their lifetime, about 1/3 of people who have been diagnosed with AFib will have a stroke if not treated appropriately with anticoagulant medications. So AFib is a major cause of stroke, and any patient with AFib needs medical attention to decrease that risk because it is very common.
But this is important. That doesn't necessarily mean that every patient who has AFib is going to have a stroke.
Does not.
No, and I think that this really emphasizes the importance of a relationship with a physician and really discussing this with their doctor, that not only does the presence of atrial fibrillation increase the chance of stroke, but there are other risk factors that I think Dr. Mahoney was alluding to as well that patients should be evaluated for. For instance, not in addition to people's demographics, their age, their gender, do they have a history of high blood pressure? Do they have a history of heart failure or reduced heart squeezing function? Do they have a history of vascular disease or heart attack? When we meet a patient who has atrial fibrillation, these are all factors that we take into account to try to personalize their approach, because people may have different risk factors for stroke.
So just insight into my family. I have relatives who have AFib. We talked a little bit about some of those other factors, and you may have touched on it, I might have missed it in the list, but genetics, family background, is that a big determining factor as well?
So I think it's definitely emerging. Right now, we're now just in the infancy and, initial stages of genetic tests to actually look at predisposing factors. But we hope in the future that genetic testing will guide therapy in the same way that it's guided therapy for other ailments as well.
Let's talk a little bit about the ways in which we treat folks who have this condition. So, what can we do? And we talked about the importance of those relationships between patients and physicians. So as to when you receive these treatments, that obviously would be something you would want to discuss with your doctor for your specific situation. But what are the types of treatments that we do for patients in this space? And Dr. Mahoney, we can start with you, or Dr. Katz, whoever wants to go first. At what point would we encourage patients to seek medical treatment to lower that risk of stroke?
So any patient who's been diagnosed with AFib or is concerned that they have any irregularity in their heartbeat needs to see a physician. So the simple answer is immediately. And to allude to what you were talking about before, they need a strong relationship with a primary doctor, because atrial fibrillation can be a cause of many problems, but it also may be a symptom of other problems, such as obesity, sleep apnea, patients who sometimes imbibe too much alcohol or too much caffeine. All these things can make AFib more likely and more difficult to treat, and as a result more dangerous. So patients should immediately seek medical attention with a physician, whether that be a primary doctor or cardiologist, to have their whole system evaluated, and that's very important. As for types of treatment of AFib, we think of it in 3 main ways. One is we want to control the heart rate. 2 is we want to make sure that they're on a blood thinner if appropriate to decrease the risk of stroke. And 3 is do things to control the rhythm to alleviate their symptoms. But when you focus on the stroke risk, you take a patient who can have a 14% per year risk of stroke, and on appropriate medications such as the blood thinners we have today, their stroke risk dramatically decreases to about 1%.
Wow.
With a well under 1% risk of any side effect on that medication that is life-threatening.
So this can make a huge difference for
Yes,
folks.
a very big difference. So you're taking a population who about 1 out of 3 of them will have a stroke and dramatically decreasing that risk.
Dr. Katz, let's just, for those who, again, may be hearing about this for the first time, and hear the term blood thinner, and maybe you aren't familiar, perhaps they may have heard it advertised for on television or something, right? And just aren't really familiar with what that is. Can we explain?
Sure. Blood thinners, or the term we commonly use is anticoagulants, are medications which are taken on a routine basis to prevent clot formation. In prior days, the most common one which was prescribed was warfarin, which required laboratory testing to make sure that this medication was in range, meaning that it was adequately thinning the blood, but also to make sure that the dosage was not too high. In the more recent era, there are medications that require less laboratory testing, but still require longitudinal testing. These can be taken, and there is less of a concern with interaction with foods, although it does need to be under the supervision of a physician because, of course, drug interactions are common as well.
Well, I mentioned in the beginning that it's a conversation that we're having, but this is also a conversation you can participate in too, and we have received a number of questions, so I want to touch on a few of those as well for our doctors. And again, if you hear something that you think maybe relates to your specific life with maybe some nuances and want to ask that question, feel free to do so as well. Carol asked about something that, Dr. Katz, you were just touching on slightly, which is some of those behavioral and dietary things that can influence our likelihood for AFib or the way in which our AFib is exacerbated. Let's talk a little bit about that. What do you recommend from a lifestyle and dietary perspective for patients to manage some of those things so that maybe medication isn't necessary? For either of you, what would you recommend?
Sure, and again, this is an emerging area of research and interest, and we look for more clarity even in our guidelines with regard to diet and lifestyle. In general, for people who are already struggling with obesity, we know that weight loss can be tremendously important. And we know that sustained weight loss and a reduction in BMI can reduce the incidence of atrial fibrillation and also its symptomatic manifestations. So we partner with our primary care doctors and even specialists in the field like bariatric surgeons in extreme instance to actually assist people on that journey, and that can be extraordinarily challenging. Dr. Mahoney was commenting on intake of alcohol and caffeine, and we find in our conversations that people have very specific triggers. So Dr. Mahoney, you may want to comment more about that, but
avoiding that extra cup of coffee, maybe.
Right, and I think that all these things are moderation is key with everything, especially when trying to discuss with your patients how to decrease their risk. Again, it's healthy lifestyle choices, decreasing caffeine, decreasing alcohol, weight loss, exercise. All those things help the AFib become more manageable and make it less likely to be a problem down the road. However, you have to underscore the point that even if you become a world-class athlete, you still have AFib most likely, and you need to very carefully follow up with your physician.
So it's not a condition that goes away just by being in great shape.
No, it's not.
Dr. Mahoney, feel free to cut me off when I say this, but I think the analogy...
we love it when our guests have that interplay.
I think that, the analogy I give to a lot of patients is a lot of these lifestyle factors, including aggressive treatment of sleep apnea, are almost like fuel on a fire.
Okay.
Right. And, turning off the hose or the pumping gasoline into the fire doesn't necessarily put it out. But, it's certainly very hard to fight a fire while you're actively feeding it.
Pivoting back to something which we talked on before we got into our lifestyle conversation around the use of blood thinners. Mm-hmm. Are there circumstances under which a patient might not be the right fit for them, that maybe a blood thinner is not a good way to go? And then in that case, are they stuck with whatever symptoms come from their AFib and not being able to manage them?
So just to correct, the blood thinner question isn't about the symptom, it's about the risk of the stroke, as we discussed. So there is a ever-growing population of people who cannot take blood thinners. About 80 to 90% of patients can take a blood thinner throughout their lifetime without having to stop. The problem is, as our population is getting older, that population is at risk for falls, which can lead to significant bleeding.
Right, sure. And
internal bleeding over time. So if a patient has had recurrent bleeding or is at risk for falls, it's a very difficult thing to deal with because the primary physician or the cardiologist or us, the electrophysiologist, we're trying to determine what's best for the patient. And you're trying to determine, is it best to keep them on a blood thinner to avoid, a 15% possible risk of stroke in this one patient per year? Or is it a bigger risk to leave them on it, God forbid they fall and hit their head and have a bleed in their head? So especially as the population ages, we're having a larger pool of patients who the risk-benefit becomes somewhat unclear. The reason why that's important to identify now is that the choice, although still difficult, has become a lot easier with some interventions we can do to decrease the risk of stroke. The most common thing we do is something called the Watchman device. And what that device is a mechanical occluder of a part of the heart where strokes form. So as we discussed earlier, when a stroke occurs, it's because the blood isn't pumping very well in the heart. That's an oversimplification of what's going on, but anatomically, the area this happens is in a outpouching. It's almost like the appendix of the atrium. It's basically an accessory area of the left atrium where blood tends to pool. And we can seal that area off from the rest of the atrium with a small little device that looks like a parachute. And we've done well over 100 of these now at Morristown. And we find that within 6 weeks, if the device is appropriately placed, which 95 to 99% of the time it is, patients can get off of these blood thinners and going forward have the same risk of stroke that they would if they were on Coumadin, for example, which was what it was compared against. So not all patients can have blood thinners, and it used to be a sometimes catastrophic situation because the patients were waiting for either which one of the next shoes would drop. Either they're on the blood thinner and they fall and get a bleed, or they have a stroke. But now with this device called the Watchman, which is a simple single puncture in the vein, and we place this device in the heart, patients go home the next day, there are choices. That being said, the Watchman is a second-line choice for patients who cannot tolerate blood thinners.
With blood thinners being the primary then suggested course of treatment.
Because if you can avoid a procedure, the procedure has risks, obviously, and the risk of the procedure up front is similar to the long-term risk of the blood thinner. So if you can tolerate the blood thinner, it's best not to go through the procedure.
So let's take a couple more questions. We have one that has come in from Ezra that asks, if I had an ablation and the ablation helped me significantly, what are my chances of getting a stroke? And indulge, for those of us who may not know what an ablation is, can we explain what that is, and then we can answer Ezra's question.
Sure. So an ablation, just to begin, is one of the therapies we use to actually maintain sinus rhythm. This is part of what we would call a rate control strategy.
For your heartbeat, the rate of your heartbeat.
That's correct. And what we end up doing is actually, it's a catheter-based procedure. It's not open heart surgery. But in our operating room, we enter the veins of the leg, travel up to the chambers of the heart, and actually seek out the locations within the heart which we believe to be the triggers of atrial fibrillation. So by performing cautery on the inner surface of the heart, we can modify and significantly decrease the chance that a patient may actually go into atrial fibrillation.
And as such, then answering Ezra's question, which was, what are my chances of getting a stroke if the ablation helped?
Right.
Significant. We may not be able to put a number on it, but
So-
better than if you didn't have the ablation?
This is why a conversation with the doctors is important, because the atrial fibrillation has two issues. One is three issues entirely, but to simplify, one issue is how does it make the patient feel? And the other one is what dangers does it pose to the patient, okay? And although we have to look at them as mutually exclusive, although we know they're not. Just because someone has had a successful ablation, about 80% of people with certain types of AFib will never have AFib again. That being said, if the patient is very high risk for stroke and has a 20% chance of having AFib in the future, we would recommend they stay on a blood thinner regardless of how well they do after the ablation. The reason for ablation is not to stop the blood thinner or the anticoagulant. The reason for the ablation is to make the patient's atrial fibrillation go away to treat the symptom side. So again, it's a quote cure of the symptoms,
Right.
but we don't remove your atrium, and the atrium and your risks are the problem. So we have to, it's two different facets of treatment.
So, I just wanted to build off that. Dr. Mahoney had made a very nuanced point very early to answer one of your first questions, that we've come to an understanding that atrial fibrillation is not only the cause of strokes, but atrial fibrillation may appear as a result of other risk factors for stroke.
Okay.
So this is a very counterintuitive point, and we actually get a lot of referrals for this sometimes, where people say, if you can take away my atrial fibrillation with ablation, can I just stop my blood?
Yeah, then I don't have to worry about a stroke or anything like that.
Right.
But what we find is that people's future risk of stroke is actually guided by other risk factors they may have. And we had briefly touched upon this. One of the most common risk factor scores we use is called the CHADS-VASc score, which
CHADS-VASc score. Got it.
where all of these letters stand for a different risk factor.
Okay.
So those risk factors would be C stands for the presence of congestive heart failure,
Okay.
but also hypertension, age, diabetes, prior history of stroke. So once a patient accumulates a number of risk factors, it has to be a pretty involved discussion with an electrophysiologist or a cardiologist on the risks and benefits of ongoing anticoagulation.
And I think it's a very nuanced point as well that, like Dr. Katz explained, even in the best outcome of ablation, where a patient doesn't feel like they're having AFib anymore, it's not a simple question of the AFib alone causing the stroke. There is some data that post-ablation people have less strokes. Okay, there's actually pretty good data with that, but that's not strong enough data to say that we don't need to worry about stroke at all. It might make it less frequent, but it doesn't absolve the patient of the need to consider further treatment.
I think this is a good time to also mention that for those members of our audience who may not have a physician that they have a relationship with yet in their lives where they can have these types of conversations, that is a resource that our website can provide to you as well. You can go to atlantichealth.org and find a doc, which is right there at the top. You can sort by cardiologists, you can sort by neurologists, you can sort by all different kinds of specialties, so that if you, or even just primary care physicians, if you don't have somebody in your life that you have a relationship with who knows you and your medical history, or maybe you moved into the area, use that as an opportunity to make those connections, because a lot of these relationships seem like they're important.
Not to cut you off, but I think is with acknowledging the risk that I might be carrying the flag for Atlantic Health, and that's not what we're trying to do. I think that
sure.
that that organizational structure of medical care, like is at Atlantic Health and other organizations, is very important, because although we're very well trained and we have many areas of expertise, diabetes management with AFib is just as important. You're going to need a primary care doctor for that. Risk of valve issues in the heart, high blood pressure, cardiologists will get involved. People with kidney disease in that front. So it's a
Pulmonology
one
for sleep
patient.
apnea.
Yeah, it's a one patient multidisciplinary approach.
In touching on some of these, Richard asked about the Watchman. So Richard, hopefully if you're watching, you got your answer to that question. Victor wants to know, atrial premature beats and ventricular premature beats, what are the dangers of each of those? Are there dangers in each of those? For either of you who want to answer it.
Sure. So just by way of explanation or providing a definition, atrial premature beats and ventricular premature beats are exactly what they sound like. That, I always start by saying none of us are built like a machine, right? A machine is perfect.
Not
right?
on our best.
With a heartbeat coming in, exactly. So a premature beat is an early beat.
Okay.
Right? And many people, if you were to do an EKG in real time, have these. However, there's a wide variation in the fact that for most people it's completely asymptomatic and there's no sensation.
You wouldn't even know.
You wouldn't know, right.
But some people feel them, and they can be distressing, particularly if you don't know what they are. All of that being said, there is a standard workup and evaluation, which usually begins with a primary care doctor or cardiologist, where if someone has a structurally normal heart and there are sporadic premature beats, both from the atrium or the ventricles, these generally do not have a lot of clinical meaning and are not necessarily related to the development of either atrial fibrillation or more dangerous rhythms from the lower chamber of the heart.
Well, hopefully that puts Victor at least a little bit
at ease.
Yeah, a little bit at ease, exactly. We have a question that just came into us. Karen is asking, is SVT or are SVT and atrial fibrillation completely different, or are they related? What's the answer to that?
So the answer is yes, but to clarify that,
Sure.
SVT, it used to be a term that was describing any fast rhythm in the upper chambers of the heart. Atrial fibrillation classically is a type of SVT. However, now in the vernacular of society and especially medical society, they're thought of in two different ways. SVT, whereas atrial fibrillation is complete electrical chaos, SVT is a repetitive mechanism where the heart goes fast. SVT typically doesn't have the associated risks of stroke. It is very rarely a cause of secondary phenomenon such as the heart function going down. So SVT they're both upper chamber arrhythmias, but SVT is a completely different mechanism. And it's something that really symptoms guide our treatment more than an AFib, where symptoms are just part of the answer.
Great. Good question, Karen. Thank you very much. Marlene wants to know, if you're being treated for AFib with anticoagulants or blood thinners, right, as we learned today, and you suspect you may be having a heart attack due to sudden heart pain after exertion. So the pain after the exertion is giving the indication that you may be having a heart attack. Marlene wants to know, can you take aspirin while waiting for first responders to arrive and to help you out?
The short answer is yes, that's probably okay in accordance with physician's instructions.
Sure.
Many of our patients are prescribed low-dose aspirin in addition to a systemic blood thinner. And we know historically that many patients who have had prior history of heart attack or stroke are maintained on aspirin for many years in addition to actually taking blood thinners. But the short answer is if she suspects that there may be a heart attack going on, there shouldn't be any problem doing that.
But she should be on the way to the emergency room.
Yeah, I would say let's get
Yes.
the EMS there first thing. That
Right.
I think that goes without saying that seek emergent care if you think you're having a heart attack.
We only have about a minute left, and so I want to touch base. I want to just recap where we started and the importance of connecting with our physicians here at Atlantic Health. If you have any further questions, or just really even going to our website, atlantichealth.org, to learn more. But again, AFib, a condition that it seems like we have whether it's here at Atlantic Health System or other physicians, we have the science behind being able to care for folks who have this condition. So if you're concerned you may have it, seek care, right? Is that a fair way to address it overall?
I think the biggest risk of AFib isn't the treatment, it's not getting treatment. It's probably the best way to say it.
Dr. Katz, any thoughts from you before we wrap?
And I know Dr. Mahoney knows this. We know this by speaking with our patients, that it doesn't feel good to be in atrial fibrillation for many people. We've referred to this two-prong approach, not only stroke prevention, but also improvement in quality of life. And, we have excellent therapies, so we really do want to encourage people to make it to their doctor, because that's really just starting on the journey to, just feeling better on a day-to-day basis.
And there's great data that the earlier you identify and do something to eliminate it, the AFib itself, either with medications or ablation procedures, the better people do long term.
All right, we have two questions that snuck in right before the deadline. So they asked them, so we definitely want to answer them. Ron wants to know, is there a relationship between AFib and a leaky heart valve? Is there a connection? It sounds like a little bit like what we talked about in the beginning.
Yeah.
And for either of our doctors, whoever wants to handle that.
Sure. Like all complicated things, I think the answer is maybe. Right.
It's the answer I would have given, for
So
sure.
when people speak about a leaky valve, one of the more common valves they're referring to is the valve that divides the left upper chamber and the left lower chamber, the mitral valve. And there can be leakiness, or the technical term would be regurgitation, which is a backflow of blood
Got it.
in the wrong direction, traveling from the lower chamber to the upper chamber.
Got it.
As you can imagine, over time, if the blood is flowing in the wrong way, that chamber size may actually start to enlarge.
Okay.
And as that chamber
Because
enlarges,
of the volume of the fluid coming the other
that's
way.
correct.
Yep, got it. Okay.
And as it enlarges and pressures go up within that chamber, there may be scarring or changes in the muscular tissue of the heart over time. And potentially, there may be the development of heart rhythm problems along with that.
So
there
it's
may
not
be a relationship.
exclusive cause-effect, but there may be a relationship.
Yes, there's definitely a relationship, but it's one of the more rare causes of atrial fibrillation.
And then Richard wants to know, what are the risks, if any, of antiarrhythmic drugs for treating persistent atrial fibrillation?
So
If I said all those words correctly,
Right.
then good for me. But if I did not, please correct me.
you get a gold star.
All right, excellent.
Atrial fibrillation is treated with antiarrhythmic drugs to control the symptoms of atrial fibrillation. We're trying to reset the heart with medications. So if you think about atrial fibrillation as a muscle twitch, what the medications are trying to do is stop the heart from twitching or causing atrial fibrillation. There are a lot of problems with antiarrhythmics long term, including some of them can cause very slow heart rates, some can cause nausea, any side effect of any medication, and rarely they can cause deadly arrhythmias. So when you choose an antiarrhythmic, you have to do this very carefully. In addition, there's more and more data that ablation is more effective than antiarrhythmics when you do an ablation in the appropriate patient. So antiarrhythmics are something that once they're being considered, the patient needs to discuss with their cardiologist and possibly an electrophysiologist if they're concerned about side effects and the drug of choice. But there are several risks with these drugs, which is why many people choose to undergo ablation to avoid a lot of these risks.
Excellent. Richard, hope that answered your question. And I want to thank Richard and Ron and everybody who asked questions. We're a little over on time, but I think we covered a lot of ground, and so it was time well spent. So thank you
for having us.
Yeah, thank you for joining us.
Thanks a lot.
And folks, if you missed any portion of our program and want to jump back and see it from the beginning, you will be able to find the whole thing on our Facebook page. And then in short order, you'll soon find it on our YouTube channel. Those who subscribe to our YouTube channel will have it sent to them automatically. So might be a good time to do that too. But again, thank you all so much for joining us. Dr. Michael Katz is the director of the Inherited Arrhythmia Program, and Dr. Timothy Mahoney is the co-director of the Electrophysiology Lab at Morristown Medical Center, part of Atlantic Health System. Doctors, thank you so much.
Thank you again.
All right,
Thanks for the
folks.
time.
We'll see you next time.
All right, thanks.